for ZSOG, and he's the current Zimbabwe Medical Association National Secretary General. So this evening, we're really looking forward to Dr. Mateveke giving us a presentation about MURI, and then obviously, as the chair says, there'll be a Q&A session, and then we'll be able to give you a bit more background about PSI. So from the Pulse Group, we're really excited about this, bringing you this product in the market. The product is already in the market and it's available, and wouldn't be able to do this unless we're in partnership with PSI South Africa. So without further ado, I'd like to hand over to Dr. Mateveke.
Thank you so much, Inyari, for the kind introduction. Please confirm if you can see my screen and hear me clearly.
Yes, we can see your screen. We can see the folder, not the presentation yet.
Not the presentation. Maybe I have to unshare again because I had shared my screen. How do I unshare? Stop sharing. Let me try and share again. Can you see?
Yes, we can see the presentation now.
Okay, if I'm going to put it on slideshow. Can you see it now on slideshow?
Yes, perfect.
Thank you so much, Nyari. Good evening, ladies and gentlemen, and I would say fellow colleagues. I think having organized a lot of our meetings, I'm still sort of like obliged to also add to what the chair was saying. I think one of the important things is particularly those who are joining the meeting using their phones, please try to use your real name. This helps with collection of CME points rather than using your device's name, so to speak. So good evening once again and welcome. I'm particularly quite very excited to be here and giving this talk to fellow colleagues. I must say that as a specialist gynecologist, we are generally not into the business of writing prescriptions for over-the-counter medications like oral contraceptives. But it's good that we meet today discussing an oral contraceptive. I think from a specialist perspective, maybe it's a chance for you guys to recap on a few things with regards to these contraceptives and their hormones. And yes, it's also an important time to be able to be introduced to new products on the markets that definitely we can make use of and recommend to our patients. That's the outline of my presentation, and I will declare that this presentation has been prepared for medical and scientific interest only, and the content of the presentation expresses my views as the speaker and is based on my clinical experience as well as research material from various sources. So what is contraception? I think it's synonymous with the word family planning to the general population, planning a family. So it essentially involves the voluntary control of fertility through processes where we interfere with the normal process of conception. So we are essentially talking about provision of the gametes, that's your sperm, your ovum, sperm transport through the uterus into the tubes, fertilization in the fallopian tubes, and further transfer back of the embryo into the endometrial cavity with implantation. And these are the various key points where contraception comes in to try and interfere with the process. And when we're talking about combined oral contraceptive pills, you will find that as my talk goes on, it's essentially beyond the blockage of ovulation, but that will be the primary point where oral contraceptives or combined oral contraceptives, so to speak, come in. And I think according to WHO, contraception must be efficient and reversible, affordable, and well tolerated. I'm sure we are all aware of the various myths within our societies of young girls whom you can see do qualify and should be on contraception, having this fear of being on contraception because there's talk out there that probably they might have challenges conceiving, once they stop the contraceptives. And I'm sure Dr. Manzivire and other people who do a lot of fertility work definitely have come across this question during their various consultations. And I'm sure all of us have come across some of these questions, and we all know that these are just myths. And we're here today to try and demystify some of these myths. So contraception does assure that conception is invariably achieved by choice, and definitely not by chance, and it has become a basic human right. The National Survey on Attitudes and Lifestyles in the UK did note that this was done between 2010 and 2012, reported that more than a third of UK women aged over 16 to 44 years had used some kind of contraception within the previous year. However, they didn't invariably distinguish between use of combined oral contraceptives and progesterone-only pills. And the United Nations, in their report on contraceptive use by method, this was done in 2019, did note that 44% of the world's population was indeed using these modern methods of contraception. And I'm particularly interested in the 190 million, which is the 10% gap, which definitely needs to be met. And some of the highlights from the United Nations report, which I've put up on the slide, of particular mention was the finding that methods designed to be used by women do account for most of the contraceptive use, actually. And we are again seated here today discussing definitely a method that many women actually use. And also another key finding from their report was the fact that short-acting contraceptive methods are more common in sub-Saharan Africa and Europe. And here we are in sub-Saharan Africa, and again sitting today talking about one of the short-acting methods of contraception, which is your combined oral contraceptive pill. And my talk would not be complete without highlighting the impact of what the global pandemic has done when it comes to the use of contraceptives, particularly when you're focusing generally on the underuse of these oral contraceptives. And we note that during the evolution of the pandemic, from the first days, which was last year, there was a big scare. Everyone was in panic mode. Lockdown restrictions came into effect. Everyone just sort of like retreated into their hives and caves and cocoons, trying to run away from the scourge. And healthcare provision was also not spared. And this resulted particularly in the blocking of continuation of essential health services. They were essentially neglected, and everyone was essentially focusing on case management. We're talking about COVID-19 patients. All the resources were challenged to try and build nice hospitals, to try and acquire all these ventilators in various spheres and the like. And continuation of essential health services was sidelined, and sexual and reproductive health was not spared. And I'm sure most of us here can relate to this clinical scenario, but I'm happy as the pandemic did indeed evolve. Now we've got vaccines, borders are opening up, and people are indeed actually learning to live with the COVID. As a result of that, the UNFPA did then bring out a report, and the core message from their report was that provision of modern, short, and long-acting contraceptives, information, counseling services, including emergency contraception, is life-saving and should be available and accessible during the COVID-19 pandemic. I think these are the messages that we also need to resonate within us and within our various spheres of practice. And I'm glad to say, as Zimbabwe, we also were not left behind, and as we speak, Zimbabwe does have a robust COVID-19 operational plan, and set up against various pillars, with Pillar 7 being the case management. And I'm happy to say I've been directly involved in the case management, and we did work significantly to improve the issue of continuation of essential health services, including sexual and reproductive health. And there was also a report from the revised humanitarian response master plan for Zimbabwe in 2010, which also did echo the same sentiments, saying maintenance of essential health services aligned around the following, including immunization services, maternal and newborn health services, community health services, mental health services, behavioral change. I must say these efforts were trying, essentially when you're focusing on sexual and reproductive health, particularly family planning, and we are worried about anti-use of these various contraceptive methods, and COVID-19 comes into effect and even blocks all these efforts. So you can see that the messages that are resonating now are trying to push for a continuation of these services and making sure that everyone will have a chance to make babies by choice and not by chance. Belize, in his publication in 2015 on underuse of modern methods of contraception, underlying causes and consequent undesired pregnancies in 35 low and middle income countries, and 87 million people worldwide become pregnant unintentionally because of the underuse of contraception. And the information was collected from demographic health surveys in 35 countries, and I'm glad to say Zimbabwe was included. And the data was collected between 2005 and 2012. Demographic health surveys are essentially national household surveys that are generally used to collect data that you can use to analyze issues to do with the health, issues to do with the population, issues to do with nutrition. And I think most nations do participate in these demographic health surveys. They noted that out of their findings, 15 million out of 16.7 million undesired pregnancies could have been prevented with the optimal use of modern methods of contraception, which is quite disheartening. Under use of modern methods of contraception does indeed burden, especially the poor, and particularly those who are less educated. Since the proof of concept by Gerasi and Pincus in 1960 on the oral contraceptives, the first pill that was containing norethindronel as a progestin and mestranol as an estrogen, I think this was called back then Inovid, many different compounds have been developed since. I think maybe I can just take you back and give you a little bit of history. So what essentially happened in the 1950s, norethindronel was, I think, the first clinical trial on the use of these hormones as contraceptives, of a progesterone as a contraceptive, was done on the norethindronel. And it was done in Puerto Rico. Interestingly, because of the high birth rate that was actually happening at that time in Puerto Rico. United States was close by. They could have definitely done the same, the same study, sorry about that. They would definitely have done the same study, but they were worried about potential ethical issues in relation to sort of like doing a clinical trial on contraception amongst their population. So yeah, they did it in Puerto Rico. And what then happened was during the first phases of this trial, they realized about 1 to 3% of the norethindronel that they were using was actually contaminated with a methyl ester of ethanol estradiol. So in their efforts to try and purify it and continue with the trial, they realized that those who were now on the purified norethindronel had a lot of breakthrough bleeding. Hence, that's how mestranol, which is essentially a methyl ether of ethanol estradiol, was by stroke of luck discovered as a potent estrogen. That's when it was essentially manufactured and was actually noted to be a potent estrogen. And from then on, Gerasi and Pincus then started doing studies to try and look at how best they can combine these two to come up with the contraceptives, and they successfully did it by 1960 through their proof of concept. So at the moment, ethanol estradiol sort of like overtook mestranol as the primary estrogen in combined oral contraceptives. I think this was particularly driven by the fact that during the first years of Innovit, which is essentially the noethindronel and mestranol, they noted a significant increase in venous thromboembolism. So ethanol estradiol, being a metabolite of mestranol, was found to be actually much more potent by weight compared to mestranol. I think the dose of mestranol in the first combined pill was around 150 micrograms. You can imagine, that's a very high dose. And when mestranol is metabolized in the liver, by demethylation, I think the conversion rate is around 70%. So you need 35 micrograms of ethanol estradiol for every 50 micrograms of mestranol. So they realized by weight, we can actually halve the dose of this ethanol estradiol. And the hope was that it's going to significantly decrease the risk of venous thromboembolism. I'm not sure whether that was ever proven from what you call it, from that time. I mean, comparing that reduction from 150 to about, well, they were still using slightly higher doses of ethanol estradiol, which was around 35 to 50 micrograms, so to speak. I will say that besides this, effectiveness across all generations of oral contraceptives remains the same, and quite very high with perfect use. And we want to worry about typical use. So, which is the type of use that most of our patients actually, how they use the oral contraceptives, so to speak. In a report from, I think, the Royal College of Physicians and Gynecologists, they note that up to 7% of women will invariably fall pregnant with typical use of these, in a year, with typical use of these oral contraceptives, as opposed to perfect use, which would be comparable to even your long-acting methods. Of course, we also worry about drug interactions with the use of oral contraceptives, particularly, I mean, we're talking about the role of the liver in metabolizing these hormonal contraceptives. And a lot of drugs can have definitely a negative or positive effect, particularly on the outcome of efficacy when it comes to the use of oral contraceptives. Issues to do with malabsorption, and we know obesity has become a significant problem worldwide. And with the introduction of surgeries to curtail obesity, this actually affects absorption for oral contraceptive pills. But I must say, to mitigate most of these issues, they do come in various forms. Besides the pills, we do have transdermal patches, that, as well as the intravaginal rings. This tends to bypass the liver. And there are much newer contraceptives, be it oral or even what you call it, injectables as well. Much newer contraceptives that come in the form of injectables, but that's not the talk, the gist of my talk today. And yes, once we are discussing with our patients, I'm sure right from the word go, people were worried about venous thromboembolism, and we're also worried about so many other medical conditions while these people are taking oral contraceptives, particularly uncontrolled cardiovascular risk factors. So it's always very important to employ tools that one can use to be able to evaluate medical eligibility for starting a particular contraceptive pill. And one tool that I use myself is the World Health Organization medical eligibility criteria will. It comes in the form of a will. Unfortunately, I had one close by, but I am not sure where I placed it. But I'm sure most of you have come across it and seen it. It's quite a very useful tool. There are so many other similar tools provided by the United States as well as the UK, and they do perform equally well. I encourage each and every one of us to be able to use these tools, particularly when we're counseling about our patients about contraception. Oral contraceptives also do have non-contraceptive benefits. I think this is where we essentially come in mostly as specialist gynecologists, because we don't routinely prescribe oral contraceptives, so to speak, except in situations where we actually identify a particular benefit for a patient. I think everyone can agree when we are talking about our PCOS patients. There are certain contraceptives that we know have the disadvantage of having a greater anti-androgenic activity and things like that. And that's when we generally start prescribing most of these oral contraceptives. So to highlight some of these benefits, use of combined hormonal contraceptives can indeed reduce heavy menstrual bleeding and menstrual pain and acne. Use of combined hormonal contraception may be beneficial for women with premenstrual syndrome. Use of combined hormonal contraception can reduce the risk of recurrence of endometriosis after surgical management. And they can also be used in the management of acne, hirsutism, menstrual irregularities that are associated with PCOS. And we also note a significant reduction in the risk of endometrial and ovarian cancer that increases with the duration of combined hormonal contraceptive use. And also use of these combined hormonal contraceptives is associated with a reduced risk of colorectal cancer. I think we probably must applaud the scientific community. If you roll back to the 50s and 60s, just by a stroke of luck, we ended up discovering the first synthetic estrogen and doing a study to validate the use of a combination of progesterone and estrogen as a contraceptive. And now we have actually identified all these other non-hormonal, non-contraceptive benefits that we can get from the use of these combined hormonal contraceptives. Excuse me. Ethanol estradiol containing contraceptives are generally not indicated in women with a high risk of deep venous thrombosis. I'm sure we all realize that this has been quite a big problem right from inception, right from the time that oral contraceptives were identified. But you find that over time, a lot has been done to try and mitigate this. But the take-home message today would be the overall risk generally of venous thromboembolism is low. And the other challenge we have with venous thromboembolism is there are a lot of confounders. I'm sure that's why that medical eligibility criteria tool from WHO or from all these other associations comes in quite very useful. We are talking about things like obesity, things like smoking, which are quite very common within our population, and which tend to also increase the risk of deep venous thromboembolism. So it's quite very, very important for you to evaluate these metabolic and cardiovascular risk factors as well as risks for deep venous thromboembolism before you actually prescribe contraceptives. But the important message is that generally, all things being equal, the overall risk or the relative risk of deep venous thrombosis is generally quite very, very low. So combined hormonal contraceptives can be used safely within our population. So the estrogen component of combined hormonal contraceptives mostly works by blocking ovulation, and it has a dual effect both at the level of the hypothalamus as well as at the level of the pituitary, which eventually results in suppression of the release of follicle stimulating hormone that's impairing follicular genesis. And it also stabilizes endometrium to prevent metrorrhagia. And we've got so many times I've talked a lot about how ethanol estradiol came into being, and with its predecessor, which is It's methyl 3-methyl ether, which is mestranol, and now we also have estradiol valerate, which is commonly and synonymous with our newer generation injectable combined hormonal oral contraceptives. They normally use estradiol valerate for that in a depot form. And the good thing is that patients can be using it at intervals of a week to 4 weeks with so many other uses, including management of hyperestrogenemia. We know they use these injectables for management of prostate cancer and the like. Progestins are generally derivatives of testosterone or your natural progesterone, so to speak, save for drospirenone, which is a derivative of spironolactone. In 1934, the first progesterone was produced. It was ethyl testosterone. And we note this grouping of progestogens into generations, which is generally arbitrary and inconsistent. And it's not uniform because some use the year of introductions and some use the issue of biochemical families. But you find that if you're using biochemical families, just a small change on the estrogen molecule, particularly you move the methyl or the hydrogen group, has got a significant change, actually results in actually changing how the resultant chemical is actually going to have post-receptor effects. So it's very difficult to really group them into biochemical families. If we are going to group them into the year they were introduced, which is what you will find generally in the literature, first generation progestogens were indeed approved around 1973, and norepinephrine is a typical example. Second generation progestogens were approved between 1973 to 1989, and levonorgestrel, which is quite a very common progestogen, particularly used in contraception, either alone or in combination, is an example. We do have third generation progestogens. These were approved between 1990 and the year 2000. And I would say this is the main focus of my talk today. And an example is desogestrel, which is a key component of the new oral contraceptive called Muri. We also do have a group now grouped as fourth generation, and this was approved after the year 2000. And one particular good example is your norgestimate. You've got other ones like drospirenone that you essentially find in yasmin. You've got hybrid progestogens like Dienogest. I'm sure those who do a lot of endometriosis work, they have used Dienogest. And it's also used as a contraceptive in combination with estrogens as well, although at the current moment, I don't think it's available widely. So how do progestogens work? They also do have an antigonadotrophic action by inhibiting the LH stage and preventing ovulation, but this activity varies amongst the progestogens. And you will find that because we do have estrogens that they are combined with, having a very potent dual inhibition of ovulation, the addition of progestogens logistically add to its effectiveness. Progestogens do thicken the cervical mucus, and indeed this affects sperm viability, penetration, and capacitation. We know sperms have to be prepared in the cervix to have the arsenal to be able to go and fertilize an ovum. And by making the cervical mucus very hostile to sperm, you actually add to the contraceptive efficacy. They also desynchronize the endometrium, which interrupts implantation, because we know the endometrium has to be in sync with the process happening in the ovaries until the time of ovulation, such that if we do have an embryo that has been formed, the endometrial lining is receptive to the embryo and implantation is permitted. Progestogens affect this synchronization, resulting in desynchronization and interruption of implantation. They also do affect tubal motility and ciliary action. Progestogens do have a complex mechanism of action in target tissues beyond what I have described when it comes to their mechanism of action for ovulation, because they do have the potential to inhibit, stimulate other receptors, including your androgen receptors, glucocorticoid receptors, and mineralocorticoid receptors. So there is indeed a need for progesterone receptor specific progestogens to minimize unwanted effects. So the biggest challenge we have with our early generation progestogens, your group 1 and group 2 what you call it, progestogens, is generally a potential for positive activity or negative activity at some of these receptors, whose function has got nothing to do with ovulation or interruption of ovulation. Hence, there's potential for unwanted side effects. The ideal progestogen for contraception should have very high progesterone receptor activity and very minimal or no androgen or glucocorticoid or mineralocorticoid receptor activity. And we know the ones that do have significant progesterone receptor activity are newer progestogens like trangeston and nestoron, but these are then followed when it comes to activity on the progesterone receptor by desogestrel as well as levonorgestrel. Desogestrel and levonorgestrel are quite very comparable when you're looking at progesterone receptor activity. And this table is just trying to highlight activity of these progestin agents on various receptors and the resulting effect. And if you're looking on the third generation or third group of progestogens where we have desogestrel, it does have minimal estrogenic activity, but profound progestational activity, which is a key activity that we want in contraceptives, and quite minimal androgenic activity. So your third generation oral contraceptives are essentially a combination of a low dose of estrogen and combined with a potent third generation progestin. Why do I emphasize on the low dose? I'm sure when you joined this talk quite early on, we were talking about the story of mestranol and the first combined oral contraceptives and how ethanol estradiol ended up overtaking mestranol. And this was particularly as a result of the VTE risk and the mitigation by lowering the dose much lower. And we do have very low estrogen concentrations in our combined or in our third generation combined oral contraceptives, and combined with your third generation progestin, and one of them being desogestrel. And the common brands, initially we had, I think Marvelin also contained desogestrel. I think this was early in the 80s, and it was quite a very common combined oral contraceptive. Now with Muri, Cariva, Minulet, Famodin, as well as Previfan. So one of the most important things with third generation oral contraceptives is the reduction in potential or even to have neutralizing effects for metabolic and vascular impact. We are talking about its now or minimal effect on other receptors that are not progesterone receptors. They are also quite highly effective, will achieve very good cycle control, will help in reducing premenstrual syndrome, reduce dysmenorrhea, reduce premenstrual mood and fluctuations, as well as breast tenderness. And these are some of the non-contraceptive benefits that you would get. This slide is just showing the affinity of progestins for the different steroid hormone receptors. And you can see 3-ketodesogestrel, which is the active metabolite of oral desogestrel, having very high progesterone receptor activity. which is comparable also to levonorgestrel. But you can see there's very minimal androgen receptor activity, practically no estrogen receptor activity, and very minimal glucocorticoid receptor activity, practically no mineralocorticoid receptor activity as compared to natural progesterone. So a combination of ethanol estradiol and newer progestogens is very complementary in suppressing ovulation, achieving good cycle control, prevention of endometrial hyperplasia, plus the anti-androgenic and anti-mineralocorticoid sort of like activity that is achieved. So you find that these favorable unique properties in these individual third generation oral contraceptives, because we do have different third generation progestogens, and make them quite very good for our patients and a good choice to recommend to patients. The main advantage, which is quite very common with most oral contraceptives, is the effectiveness. The effectiveness does not vary across these generations, so to speak. And the fact that they've got more progestational effects, minimal androgenic effects, and minimal lipid profile modification. But as I had alluded to earlier on, it's important to screen for personal metabolic, vascular, and carcinologic risk factors. So to conclude my talk, I would say since introduction in the 1960s, many different combined oral contraceptive compounds have been introduced. Efficacy and mechanism of action for preventing pregnancies is similar across all of the generations of combined oral contraceptives. A much lower dose of estrogen in third generation combined oral contraceptives is associated with a reduction in potential estrogenic side effects. Combination with third generation progestogen compounds results in significant reduction in androgenic side effects. Third generation oral contraceptives remain highly efficacious and are well tolerated even with typical use, and measures to increase uptake in low resource settings, particularly during this stage of the pandemic, will go a long way in reducing the burden of unwanted pregnancies, particularly in the vulnerable population of the low socio-economic status and those amongst our population that might be less educated. I think with that, that's the end of my talk. I thank you.
Thank you very much, Dr. Mateveke, for the highly informative talk. Before we entertain any questions, I'm going to invite Sibongile from PSI to give us an overview. Those of you who already have questions, you can put some on the chat box. I also remind people to register using the link which is in the chat box. You should click it to open a window where you can put your details. Thank you very much. Sibongile, you can go ahead.
Thank you so much. Good evening, ladies and gentlemen. I'm going to try and share my screen. Dr. Mateveke, if you can just give me.
Yeah, I did unshare, Sibongile.
Okay, thank you. Please let me know when you can see my screen, then I can start.
We can see it.
Thank you. Just by way of introduction, I'm Sibongile Mngadi from PSI, South Africa Social Enterprise based in Gauteng. I head up the pharmaceutical division of the social enterprise. Really what I want to share this evening with you is I want to introduce the social enterprise to the audience, and really just to clarify why we felt as PSI it was important to get involved in the market in the country from a sexual and reproductive health perspective. You would have heard Dr. Mateveke mentioning that routinely, your specialty doesn't necessarily initiate script for your oral contraceptives. Where you find that you may need to use it is where you're looking for the added benefits for your patients. But what's important for us is that this is just more than introduction of Nuri into the market as far as your specialty is concerned. We're trying to develop a relationship and a partnership with you, because this is not just the end. 2 years ago, we did introduce an emergency contraceptive pronta, which is already in the market. This time we're introducing NURI, which is the combined OC. Soon we'll be bringing other long-acting reversible contraceptive methods. And that is where we find that you use those routinely. So I just want to quickly run through why we're getting involved. Just a little bit of NURI in brief, and then share in terms of the snapshots of what we are, what is in the pipeline that will really be of routine use for you, and what is the value that we want to add in the market as it stands. So this is just a slide which I generally like to show whenever I get an opportunity to just speak about who we are and why we're doing what we are doing. Because before we even entered Zimbabwe, Zambia, and all the other Southern Africa markets where we operate in, it was important that we do research, both from a consumer, patient, and also HCP perspective. The reason we did that was because we're not the first. These OCs are not the first ones to hit the market. So we wanted to find and identify where the needs and the gaps were, and actually bring in solutions to close those gaps, to meet those needs. That's where we're playing. We're playing in trying to address the needs and close the gaps that exist in the markets. So this is just some of the comments that came through from the research that was done, where some of the patients were saying, when it comes to contraceptive methods, there really isn't enough information out there to help them to make the right decision in terms of which method, when to do, when to start contraceptive methods. We also got feedback from those that would consult at your nursing clinics, where they were saying, it's often a very uncomfortable experience to go, especially when you're a young girl, to go and start a conversation about contraceptives. Things like people cannot really afford what's available in the private sector, and most public sectors, even in South Africa, where we are highly overburdened. So there was a population where they couldn't afford what is available in the private sector, but they were also not saved by the public sector because often these clinics are not open on a weekend. So for people who can only go there on weekends, that doesn't really help them. Dr. Matevege touched briefly on the issue of infertility that came through also very strongly in the research, where people were saying, I'd rather not start because at some point I would like to start a family. And I've heard that, long-term use of contraceptive methods might lead into infertility. And others were just saying, I honestly don't know what options I've got out there. So even when I do want to start contraception, I don't know where to go to. I don't know what options are available. What we did find with this last point is it's often one of the reasons why people discontinued. So those that could get on a contraceptive method and unfortunately had side effects, which were unbearable, discontinued because during the consultation process, there was never an explanation or clarity that if this doesn't suit you, come back in 6 weeks' time, let's see what else we can put you on. So this is really some of the things that really made us decide that we were going to enter into the markets to try and address this. So just why then NURI and why now? So what we are all about is we want to expand choice. And this speaks to one of the comments where people were saying, I don't really know what's out there. I don't know what choices I have. We want to ensure access. So where there are issues where even those that can access the public sector, but where there's a shortage of products not available, we're coming in and we're saying, where there are failures in the market, doesn't matter which market we operate in, we want to make sure that we correct those failures in any way that we can, small or big, by ensuring that patients never really don't have access to medicine because there's just a shortage in the market. And that means, therefore, that we have to supply consistently. We ensure in our provision and in our servicing the markets where we operate in that we never run out of stock, so that there's always consistent supply. One of the things that is also key in terms of what we do patients are saying they can't afford what's available in the private sector. So we needed to make sure that we bring affordable medicine, because if the objective is to close the gap, we therefore cannot bring something that the patients cannot afford, because then it defeats the purpose. But in bringing something that's affordable, we were very, very deliberate that we were going to bring quality products, so that it doesn't necessarily mean just because it's cheap and therefore it's of a lower standard. So if you look at some of our dossiers, you know, the products that we've submitted to MCAZ and ZAMRA and all the other regulatory bodies, most of them are WHO pre-qualified, because we needed to ensure that what we bring to the patients is of good quality. And therefore, if something is of good quality, then obviously you're going to get reduced side effects profile. But that also spoke to some of the reasons why we found that a lot of patients discontinued because of side effects. So those are the things that really we are all about. So if you had to sum up why we do what we do and what is our objective, I've tried to sum all of that in this point. So briefly, Muri, Dr. Matevege touched on this one, but the reason I'm also flighting it is because of the last point, where there isn't any significant effect on the return of fertility. And this is really speaking about the product benefits. So you've got your cycle control, you've got your reduction in menstrual blood loss, but then when it comes to side effect profile, we're finding that your third generation OCs are generally well tolerated, and therefore patients stay on it. You're reducing the chances of discontinuation, and by that you're also reducing chances of unintended pregnancies, and you're addressing the issue where people are concerned if they'll ever get to have children when they decide it's time to do so. So that's the current portfolio, and I'm talking about specifically Zimbabwe now. You know, I mentioned that we brought 2 years ago an EC Pronta. It's already in the market. We're now bringing in the Muri, which is third generation. What is in the pipeline, which is coming soon, is your long-acting reversible contraceptive method in the form of your IUDs, your intrauterine devices. The first one that we will be bringing is your copper IUD. What's notable about this devices is we also bringing a postpartum IUD, and this comes with a dedicated inserter. Because often what we found, and we've seen a lot of it in South Africa also where we are, where the doctors and the head of departments, and this speaks to mostly your public sector hospitals, where they're saying they often find that every year, you know, the same patient is coming back to deliver, just because with your standard IUDs, they have to come back after 6 weeks for the insertion. With the dedicated inserter, you can actually insert the IUD in theater or within 48 hours before the patient even goes home. So that really then takes away the risk of them falling pregnant before the 6 weeks, coming back for the contraceptive method, whichever one it is. But also it reduces the risk of perforation. So one of the things that we found also as feedback from the healthcare practitioners, those that don't use IUDs routinely, it's really because they're not so comfortable with their skill set. And the thing is, if it hasn't been inserted properly, then you run a risk of so many issues. So people just want to shy away from unintended lawsuits, from IUDs dislodging, therefore they don't use it. So the dedicated inserter allows for smooth insertion, reduction of risk in perforations, and ensuring that the woman does not fall pregnant unintended. Then your normal copper IUD with the normal inserter is just for anybody else who would walk into your rooms and you find that they are the ideal patients to actually be put on an IUD. And this is just to show you the difference in terms of, you know, what the one with the normal inserter, standard inserter looks like, and the other one with the longer, the dedicated inserter looks like. I just put this to show you, but when we do have a launch meeting, then we will really get into the details of what the inserter is all about. It really is a snapshot, like I've put it. So then what are the value aids then that we're going to bring into the market? If we're not the first company, we're not to bring in OCs and ECs, there's already that are in the market. What is the value then that we're bringing? Education and training. And this speaks to family planning and counseling programs that we want to conduct at mostly your primary care settings and your clinics. And part of doing that is trying to address the stigmas and the challenges which are associated with contraceptive use. We picked up a lot of that in the research feedback that came through. Support programs for patients, and in so doing, we're going to create platforms where patients can easily access information, and they can also get advice of where the product is available, the centers where they can actually go when they need the product. But we also felt it's important to empower women, especially those that are still climbing their career ladder or at university planning for their future. That you can control your future. If you know that you are sexually active, but you're not necessarily planning to have kids at that point, then you can plan your future, and therefore you need to take control of your future. Consumer awareness is really, really important. Other than just addressing the myths and misconceptions about OCs, we also offering general patient information on sexual and reproductive health matters. So when we look at SRH, we look at it from a comprehensive perspective. The products that we have currently brought in are just for family planning contraceptives, but we are beyond that. Sexual and reproductive health, as you would know, is just beyond contraceptive. So in the information that we provide, it's not necessarily just about the product, it's also about other matters that relates to sexual and reproductive health. And then lastly, continuous medical education and professional development for you. It is very important because we cannot do this alone. You are critical and important partners in us achieving the objectives that we want to do in the market. So it's very, very important for us that we play a very important role in your continuous medical education and your professional development. So that would be by way of whether there are articles that we can share, whether there are symposia that we would invite you to, whichever way that would add value into your professional development. That is what we are doing, and we intend to do in the other markets where we're not there yet. So lastly, then, what is our vision as PSI South Africa social enterprise for Southern Africa? We really want to create maximum health impact for patients. I think that is what drives us. We often think of a situation where, and like I say in my third bullet, we want to reimagine healthcare in some way in our minds, and when we draw it up in our heads, it's where a patient is able to consult at the comfort of their home, get a prescription delivered without necessarily leaving the house if they don't need to. But we also want to do that first having understood what is it that they need from a health perspective, and that we get based on the market knowledge. So that speaks to the research that we do, the insights that we get, and we try and then develop solutions that will really expand the options that they have for them. So the value aids that I spoke about in my previous slide in terms of creating platforms where patients can access information, patient can be able to speak to an HCP so that they really get the facts as they are without really speaking to their friends or their peers or Google, if I can just put it that way. So that's really our vision for Southern Africa, and that is what we are working towards. And with that, I'd like to thank all of you.
Thank you very much, Sibongile, for elaborating PSI South Africa regional social enterprise objectives. Thank you for allowing our women to make informed choices when they are choosing their contraception, and for also widening their choices and also putting value into client-centered care. Now we're going to entertain questions for Sibongile and for Dr. Matebeke. We can start immediately with a question in the chat box, which is asking the cost of this product. I think they're asking about memory and what's the actual monetary cost. The question put by Dr. Manshakaire. Do you have an answer for that, Simongile?
Good evening, Dr. Mazire. If I can assist Sibongile on this question. So the actual cost of Muri from our warehouse as Pulse Pharmaceutical is $437.26. This cost is in our local RTGS dollars. So what happens is that we can only recommend the retail price, but we have noted that there are differences in the margins that are placed by our dealers when the product is now in the market. I thank you.
Okay, and then before you sign off, there's a further follow-up question from Dr. Machakere, whether he wants to know whether you are distributing through Zimbabwe National Family Planning Council. I think they do majority of the distribution in this country.
So if I can answer that, from a partnership perspective, we have engaged with ZNFPC, and it was really exactly in line with that, how we can be a partner so that we are able to supply also the segments of the patients that they service. Because what we did realize from them was, other than patients in the public sector, they do also have partners that they work with to supply the private sector channels. So we have engaged with them. We'll continue to engage. I think the COVID just disrupted all the plans to continue in the discussions personally, but yes, there is a plan to do that.
Thanks, Bongile, for the response. Proshipat, you can come in. You can unmute yourself and make your contribution.
Thank you very much, Dr. Mazire. Excellent presentations from the two presenters, Bismarck and Spongile. I was just a little bit surprised that there wasn't much said about what Muri contains in terms of the drugs and so on and so on. So I think that's an omission, a major omission. I have a second point that I want to make. Some years ago, perhaps 15, 20 years ago, Prof. Kasule and myself did a lot of work to introduce Marvelon into this country with the assistance of PSI Zimbabwe. A few years after we had introduced Marvelon and it had been accepted in the market, PSI Zimbabwe lost interest in Marvelon. And I don't think you can find Marvelon in Zimbabwe at the moment. So it's, in my view, something that PSI South Africa, who are partners in this endeavor, should factor in when they introduce a new product. They should factor in the sustainability of the support for that new product, because Marvelon is not a bad product compared with Muri. So I don't see why it has not been supported by PSI Zimbabwe now for more than 5 years, perhaps 10 years.
I thank you for those comments. I'm gonna try and respond to each of those. So maybe let me start with the last one on the Marvelon issue. So what did happen is the actual manufacturer, MSD, decided to pull out of the market, and therefore Marvelon was no longer available. When we started 3 years ago, we did have prelim discussions with them because they were thinking of maybe reactivating the registration in the country so that it is available. Currently, patients that were on Marvelon, who are still on Marvelon, are getting it via what we call a Section 10(1) in South Africa. And I don't know what the right term is in Zimbabwe, but that is when the clinicians actually put through a motivation for the drug to be in the country if it's not registered. So Muri is a Marvelon, and the reason why we then did not pick up the conversations with MSD to say, yes, you can revive the registration of the product is because we had already submitted the Muri with the MCAZ. So we knew that in a couple of months' time, we would have the product registered and then be able to avail it in the market. So Muri is a Marvelon equivalent. On the issue of consistency and consistent supply, which is something that I did speak to earlier on, that is something that we really pride ourselves in. It's very important to us that there's consistent supply. So I can assure you now that in terms of what we're doing now is not for a period. We are entering the market, and that is why I want to partner with you, because we're going to be there for the long haul. So we are not going to pull out of the market. Otherwise, then we're doing a disservice to the patients, and it defeats the objective of addressing the gaps that still exist in the market. The one other thing that I will mention, though, is PSI Zimbabwe at the time was funded by a donor, and I can't recall, it was before my time, but I am aware which donor that was. So, and this is what often happens, and these are the discussions we have with ZNFPC, that sometimes you rely on donor funding, and when it dries out, there's no more funding, and therefore there's no more product. So we are a social enterprise operating as a commercial entity with a very core focus on health impact. And therefore, we will never not be able to supply just because we're not reliant on any donor funding. Then the first question that you did mention on, I think the question was, you didn't see much in terms of what the MURI contains. I think, speaking for myself, and maybe Dr. Mativeke will come in here, you know, it was when he mentioned in his slides in terms of what it is, it's a desogestrel plus an EE combination. That's what it's, in simple terms, that's what it is, and which is why it is a Marvelon generic. But that information is, you know, we can avail that from in the form of a packaging set or any other product information that you may request. So what we do with partnering with Pulse on the ground in the market is the medical reps will come and see you, and whatever information, that additional information that you require, it will come through to us, and we will gladly provide that. But it is an EE and desogestrel.
Prof, are you answered?
Yes, I'm answered. Thank you.
Okay, thank you very much, Smongile, for making those clarifications. Can we have more comments and questions? And there's nothing in the chat box, and I don't see a hand raised.
Well, I know I was presenting, but I'll probably just maybe pass a comment. I think Sibongile, to you as well. That I think if you notice, even from the literature, from the presentation, is that the significant part of the population that really needs MURI may probably not be able to afford it. You know, that is the only thing that I probably noticed, and I've noticed this question. I think this is the third time I'm presenting on this topic, and every time the first question is what is the cost, and I'm not sure what efforts as PSI South Africa you are probably making, but I've noticed one of them being trying to engage ZNFPC and try to find a way, because the people who really need MURI, which is the rest of the population within the Zimbabwean community, may actually not be able to afford MURI. I'm not sure. I think this is purely a marketing challenge for you as Power South Africa to see how best you can be able then to penetrate that type of market. But I believe this is the population that would really need MURI.
Okay. Do you have any response, Mongile?
Yes. So I think I think in his comment and question he almost answered himself, because it is true. That is what drove us to want to partner with stakeholders like ZNFPC, because there is an understanding that it really doesn't matter. You can have the best product in the world. If the people that need it the most cannot afford it, then it defeats the purpose. So whilst we are affordable in the pricing that we are offering, we also understand that there is that lower end segment that might not afford it. So what ZNFPC then does is to also address that in saying, even though we are in the private sector, we're not offering the products at the same price that an ordinary pharmaceutical company would, because we also understand that people that need the most might not be able to afford it. So that's really why we are partnering with ZNFPC, to make sure that people and patients that really need it can afford it and can access it.
Okay, thank you very much, Sibongile. I could pose a question while we're waiting for other people to put up their questions. So I think for Dr. Mateke, you didn't comment on some off-label use of this product. I don't know that it's suitable for to use Muri for, let's say, in menopausal patients. Remember, our patients cannot afford the usual mono products, primarines, and so forth. So sometimes practitioners are forced to give them combined pills. And even for patients with gonadal failure, like Turner syndrome, people can end up just giving them a combined pill to promote feminization. Do you think this product will be suitable for this, for such off-label use?
Thank you. A very, very, very interesting and relevant question, Dr. Madzire, because I think the issue essentially resolves about the debate on what will be the best contraception after the age of 40, so to speak. And with the worries of the much higher doses of estrogen in our usual combined oral contraceptives compared with HRT. And also the challenge of potential for metabolic and vascular complications, particularly venous thromboembolism. But I'm glad to say that even the NICE guidelines and the RCOC guidelines do recognize that even in people who are over 40 and up to 50 years, even if they do fit the medical eligibility criteria, after some strict evaluation to make sure that they do qualify, they recommend that even for management of menopausal related symptoms like your vasomotor symptoms, they can use combined hormonal oral contraceptives in general safely up to the age of 50, but of course with the monitoring that is essentially needed. There is not much data beyond the age of 50. I'm sure there is the issue of that scare, the pill scare, continuing it after 50. But I believe it's the same sentiments that were happening a couple of years ago when the topic of combined hormonal contraception after 40, and you can see the guideline has evolved over time. And now, the limit is even approaching to the age of 50 if after a careful selection, a patient fits the medical eligibility criteria for use of combined hormonal contraceptive. They can use it both for contraception as well as for mitigation of menopausal related symptoms. And I'm sure, indeed, Muri being a combined hormonal contraceptive, and we've discussed about the potential benefits of these third generation progestogens, would be an ideal combined hormonal contraceptive to use for that purpose. The challenge, of course, would be to say, so I have menopausal symptoms and I'm 46, so can you primarily just start by giving me a combined hormonal contraceptive because I can't afford standard HRT? I would say it's a gray area, debatable, but I'm sure given the current evidence and recommendations, one can actually safely prescribe if a patient meets the medical eligibility criteria up to the age of 50.
Okay, thank you very much, Dr. Mateveke. I don't know that there's anyone with a comment. If you can't see the function to raise your hand, you can just unmute and contribute. There are no questions in the chat box. I think there's no one with a question, so can I invite Judith to give us the vote of thanks?
Good evening, everyone, once again. Thank you, Dr. Madzire. I would like to take this time to thank firstly our guest speaker, Dr. Mateveke, for taking time out of his busy schedule to prepare this presentation from us. I would also like to thank our partners from PSI South Africa for being here with us tonight. Lastly, but most importantly, I would like to take time to thank you as our frontline workers for the work that you're doing daily to serve us as a nation. As the PAS group, we believe in doing good and we believe in doing it well. So we'd like just to take a moment to clap our hands to say thank you. We're encouraged by your work and we'll keep you in our prayers and in our hearts day to day. The last thing that I would like to say is, on this call, we have our medical representative for Zimbabwe. Her name is Mrs. Rachel Mandidewa. She's going to be getting in touch with you through your rooms, your front offices, to make appointments at your earliest convenience so that she can have one-on-one conversations with you to discuss any objections or any additional information that you might need from us as a business. I'd like to take this opportunity to thank everyone for being here and wish you a good night. Thank you. Back to you, Dr. Mazir.
Thank you very much, Judith. Are there any announcements from the scientific committee or from ZSOG leadership? Scientific committee, Dr. Verenga, do you have an announcement? I suppose there's no announcement, so I want to take it.
Maybe I can just maybe update the members on behalf of the scientific committee, since I don't know if Dr. Verenga is here. This is our first meeting for the year. We have been pushing very hard to get this started, and we are still working on content, as well as finalizing when our third quarter meetings are going to happen. We are not sure whether things will be open enough to do an eyeball to eyeball, but as plans are going, it's mostly going to be virtual. We're hoping that maybe by end of this year, if we don't have a third wave, we might probably have an eyeball to eyeball annual meeting as usual. But as it stands, we're going to continue with our virtual meetings, and the usual communication platforms are going to be used to let you know when and which topic is going to be available at the time. So for any questions, like I said, I think this is the first time that we all have anyone on our platform. We do have our new administrator, Anonzi Vincent, Mr. Vincent, and he has taken over from Veronica. I've had quite a number of people asking for Veronica. Veronica has left the organization to pursue her own personal interests. We have Mr. Vincent. I did share his contacts on the various platforms for the organization. Please, if you want to be assisted in any way for society business, you can get in touch with me or directly with Vincent.
Okay, thanks, Dr. Mateveke. I see a response from Dr. Verenga. He says the next meeting is in 2 weeks' time. And I think members might have noticed that now we had this meeting at 6 o'clock. This was following the survey which we did, where most people prefer to start the meetings at 6 o'clock. If there are any people with concerns, you can always be raising them to the scientific committee. But at the moment, we are trying to following what people voted for. Can I take the opportunity to just thank all of you for joining this meeting, and thank PAUS and PSI and our presenter, Dr. Mateveke, for this wonderful meeting. Thank you very much. Good night.
Thank you so much, and have a good night.